Okay, so if you have any questions, just raise your hand and we will bring the mic over to you. This is a great opportunity to be able to maybe ask a little bit more personal questions and just have that conversation going. So any questions, just raise your hand and we will bring the mic to you.
Good morning. I'm in my fourth cycle of DARA VRD. And so now the question is, do you do a stem cell transplant or not? I'm being seen down in Anderson and also here at Texas Health. So I know I'll do collection and freezing, but now the question is, now that I'm in a 4-drug therapy, my doctor at Anderson says that there's a good possibility that I wouldn't have to do a stem cell. How do you make the decision?
Okay, so to this date, still the transplant is recommended as a first consolidation treatment. But our data we trying to just find the information if we can kind of get rid of it and see like what's going to happen if the patient is in a deep remission and we don't do the transplant. Are we going to just have the same outcome compared to someone that has a transplant? So we have like some trials that are still immature. We don't have all the data yet. That basically we are checking the minimal residual disease for the patient after finishing that. And then if they are deeply negative, it means that we check 1 million cells and like there is no evidence of myeloma. For those population, we collect and store and we just watch them. Again, these are the clinical trials, and we don't still have any results. Most of the study, they look at the quadruplet treatment, such as yours, like a Griffin and Perseus. They are actually transplant as part of the treatment. So they are not going to answer this question on what if the transplant doesn't happen. So who should get the transplant, shouldn't? Again, the recommendation still is a transplant, but it's going to be very different. Like some people, they already have like some genetic changes that increase the chance of getting the leukemia or different type of leukemia after the transplant because of the chemo treatment. So we avoid for those population. Or if the age could be related. And I'm not talking about a chronic age because you can be 78 and just be as good as 60, but it's just a biological age of how frail you are. So that's another reason that some people, they said no transplant. What else? The cytogenetic also is very important. What kind of disease you have? Is it standard risk versus the high risk disease? And know that the high risk definition just changed in September. So like whatever you know about the high risk probably is very different now, like because you diagnosed 5 months ago. So it's all of them that really play a role. But we have the population right now that deferring transplant and do the stem cell collection significantly increased in the last 2 years compared to before. I can tell you that. Again, we don't know if that's a good idea or not yet, just because the clinical trial is still not mature, we don't have all the data. We feel more comfortable if someone is MRD negative and we collect for them and defer the transplant for them with hoping that they're gonna just do the transplant later on if it's needed. Of course.
So you would do a bone marrow biopsy with 1 million cells to check?
Now, do you know what minimal residual disease is?
Yes.
Okay. So what they do is when they do the bone marrow biopsy, they take a small piece of bone out, and then also they pull the fluid out. The first pull sent to the company. We do the colonoscopy, we look at the DNA sequencing or the next generation sequencing of the DNA. So from your first sample or the sample that has the most of the myeloma, so we send that one first to the company, they sequence all the DNA, so they have a tracking number for you available. And then when we send the second sample, when you don't have a lot of myeloma involvement and probably no abnormality that they can see under the microscope, that fluid pool gonna send to that. So because they have a tracking number, they can track and see if there is any evidence of the same cells that you have initially, you have it right now. The accuracy of this test right now is a 1 in million. They sort out millions of cells, and if one of them is positive for myeloma, they can tell you is. However, if someone says you are MRD negative, in that test means that in 1 million you are negative. it doesn't mean if they check the 10 million cells, you are still negative, because the accuracy or the sensitivity is not to the 10 million level. Does it make sense? I hope that. But that's basically the MRD definition by now. Most of the clinical trial or most of the data that you guys heard today was based on the 1 in 100,000 cells, not the 1 million. But that's basically how we decide someone is MRD positive or negative.
Question, good morning.
Good morning.
Newly diagnosed with smoldering myeloma. And I guess my question is the distinction between low risk and high risk. That's kind of where I'm at right now as far as what's the distinction there? What makes it high risk? What makes it low risk?
Okay, so that's a very good question, and I was a little bit late for Dr. Khan to explain it, so hopefully he did. But the answer to that question, in general, a couple of things that make people high risk, and as you mentioned, we have like a different group define it differently. But in general, if your bone marrow biopsy is more than 20% involvement with the abnormal plasma cell or clonal plasma cells, and if your free light chain that is involved in this plasma cell produce is uninvolved free light chain is more than 20, or if your heavy part of your antibody, that we call it M component, is more than 2 grams, and you have 2 out of these 3, then they consider you intermediate to high risk. However, we have also other things, like for example, if you have the bone marrow biopsy, they look at the FISH study or cytogenetic of it, and they find that you have some translocation around chromosome 14 that could increase your chance of having the progression to myeloma as well. Or you have a deletion 17p, or you have a TP53 mutation. These are the things that increase in the chance of progression. So if you also have those, that kind of increase your chance of just having the myeloma faster, okay? So if you meet those criteria, then we do recommend that you evaluate it for the clinical trial and see if you need to get the treatment to just prevent from the active myeloma happening. However, right now, based on the FDA, there is nothing approved for the treatment. So far, everyone's the observation. And there was one study that finished already, and they look at the Revlimid or lenalidomide as a single agent treatment for the smoldering myeloma for the intermediate. And some of the local oncologists also recommending those for the high-risk patients that they don't have any availability to enroll in a clinical trial and receive the treatment through the clinical trial. So UT Southwestern right now, this is actually my study. It's a smoldering myeloma. If you're meeting the high-risk criteria, again, like it's every definition, every trial has a slightly different definition. But if you have that one, then we can offer you to receive the treatment Revlimid and dexamethasone versus the daratumumab, Revlimid, dexamethasone only for 2 years, and then we stop the treatment. And the goal is to just see if we can increase your life expectancy. Like, for example, if you're supposed to live like 10 years, if we can increase it to 15 years or more if you receive the treatment. Also, we want to know if 2 years of treatment can prevent from myeloma happening to begin with, because right now the treatment for active myeloma is forever. So that's another things that we're trying to do with the smoldering myeloma.
Okay, any more questions? Okay, this is a good opportunity to ask any personal questions if you have some, or anything that's been talked to about during the presentations as well.
Can you help me with what it means to move from one line of treatment to a second line of treatment? If you've been on a 3 drug treatment and now you're not responding to that, what is the next line?
It depends on two important things. So one, what kind of treatment you receive initially. So what's the name of those medications? And then the second is what kind of medical history that you have. Like, for example, like most of the people receive the bortezomib or Velcade as a first-line treatment as part of the regimen. And if they have peripheral neuropathy, so that's something that you should consider the next medication that you're giving, hopefully not increasing that one, or at least doesn't have that side effects. Or it depends on the first treatment that you receive, how long you continue it. Did you relapse or progress while you're receiving it constantly, or you were on a break, like for 2 months, 3 months, and then the disease comes back? Because if the disease comes back in the first 60 days of you stopping it, you can actually not resistant to the first one. You probably just lost the effectivity of it just because the medication is off. And if you resume it, probably you're still gonna respond. However, if the relapse happened in the first 60 days that you're off of treatment, that could happen, that's right, like hospitalization, travel, or something like that. It means that you were already refractory to this disease, and the relapse would happen anyway, even on a medication or being off of medication for 60 days. So then you have to completely change the treatment. So and I do not have any stat or anything. I'm just going off based on my practice and how I see people coming to me now for the transplant. Until last year, most of the people, they were on a triple treatment, like a Velcade, Revlimid, Dex. That was a very common regimen that I would see, and now everyone changed, and everyone, since January, everyone on a DARA, Velcade, Dex, doesn't matter where they're coming from. So then the treatment also gonna be in a second line very different if you saw the DARA versus not. If you haven't, then most of the patient right now, then the daratumab is a very good medication to be added to that. And again, CAR-T treatment is a second line treatment right now, but as Dr. Anderson mentioned, this is not something that we would like to try for everyone, given the side effects. And also, it's not possible that everyone receives this medication, so the limitation of the slots and everything.
I have a question. Why is there such a big disparity among African Americans that are diagnosed with multiple myeloma?
On the diagnosis or the treatment?
Both.
Okay. So I guess the diagnosis, we know that even the MGUS, the precursor, is even higher in African American compared to the white. It's just 2 times more. And also we know that if you have it in a family member, the chance of you have it is 2 times more as well. Is that the genetic versus the environment or the biology? It's just not, I don't think that we know the answer. So they are right now in Dana-Farber in Boston, they are actually looking into that and just see if there is any genetic changes or predisposition that increase that chance, but they are still working on it. So I don't think that we know any genetic or biology. We know that it's supposed to be biology somehow, but we just don't have the answer yet. But the second thing is the environment. Because, and I give you an example, it's not about African American, I give you an example. So the veterans that they have Agent Orange exposure, they got the multiple myeloma when they actually got older. That's right. They were all in 20s and 50s. They started having multiple myeloma. So whatever happened in a young age or in earlier of your time may give you an MGUS, but you don't get a myeloma until later point in your life. So, and that's why we always say the environment is very important, and that's why you cannot really point at anything right now, because you have to just really go back and see what happened to that specific population compared to the wide population, where exactly they live, what kind of pollution they had in the past that increased their chance. So it's just so hard to answer. But it goes to the treatment that is easier to answer it. So the clinical trial is very evident for us that the Hispanic and African American, they are less enrolled in any of the a treatment, like a CAR-T treatment or something like that, or other clinical trial. One is, I guess, the historically going back to 1960s and whatever happened before, and that the people have some they're not trusting the system still, and we have a still population of multiple myeloma patients saw those days. So they are from 1960. So they saw, and this is not the This is not the history for them. This is actually something that they live. And then, so that's a trust issue when it comes with that. But the most important thing that I would say that I can see, and the study actually shows, is that the people that they are living far away from the transplant centers, like CAR-T center, like more than 60 miles, particularly low-income households, they have less access to all of these treatments, and all of these treatments are very expensive and costly. And if you get the MCAS and you just get the myeloma in a younger age that the African American could get, then they are the population that are working as well. So the logistics, how much they can be off of like a work to just actually do this treatment, also affecting receiving this treatment. The main disparity can also be the insurance. Not everyone are insured in our country. And yeah, the income, unfortunately, we know that the white population have a higher income compared to the minorities in most part, and then that could affect as well the treatment choice. But yeah, but everyone is aware of it, and they're trying to just see how they can decrease it as much as possible.
Hello.
Hi.
What is the effectiveness of the stem cell transplant for plasma cell leukemia patients?
Okay, so the plasma cell leukemia is now very common. When it happens, it's a very high-risk disease. Still, we do recommend the stem cell transplant, but I do not have exact data only for the plasma cell leukemia because it's just kind of the case series mostly. But still, we do recommend, if someone has a high-risk disease, like such as plasma cell leukemia, if we can get it under control, that right now with this treatment that we have, we can, then the treatment with the stem cell transplant is very recommended. But just having the plasma cell leukemia kind of decrease the time that you're staying in remission compared to someone that doesn't have it, because it's completely different biology compared to the other people that they don't have a plasma cell leukemia. It's a very aggressive type. But I'm sorry, I don't have data, like numbers.
And what's the differentiation of the staging for multiple myeloma versus other cancers?
Okay, so that's a very good question. So if you come to my clinic, I have like 3 different ways of staging, and then all of them are different. But so basically, the staging came, it's a blood cancer, that's right. So you cannot really stage it similar to the solid organ cancers that they would say, like staying in an area versus it's spreaded, and then you got just kind of just say how big it is. It can just, the stage is going to be very different from 1 to 3, and if it's spread to another site, then you're going to 4. So myeloma is already in blood and is everywhere. So you cannot really stage it that way. But how you stage it, you are looking at a couple of numbers that they just show like how fast the cell actually growing and dying. So those are the markers that we are looking at. And it's a blood workup, so nothing really specific. And then also we are looking at the genetic of this myeloma, because we know a couple of these genetic changes, like for example, deletion 17p or translocations, they could increase your chance of like having an aggressive disease. So if you consider as a high-risk disease, you also get a point. And then also we are looking at the LDH. So overall, we have a stage 1 and 3 if you only check those. So since 2022, they revise whatever we know, and they call it like a second revision of RISS, and that actually put the patient in the 4 different categories. Now, just because make it very simple so everyone know they are a stage 1 to 4, and that's also based on all of this and the certain number of the cytogenicity that you may have. Know that this is evolving. This is not like something that we just mention it because we know from the beginning when you stage it, you know, like some people, they're gonna live shorter compared to the others. For example, stage 3 of these categories is a little bit, they have a shorter life expectancy compared to the stage 1, and the difference is huge. But the most important things in a myeloma is not only a staging, how they respond to the treatment, refractoriness, and like how fast they go from one line to another line is actually important as well. And that's going to change as well, because the definition of high risk now is changing. but all the staging is based on the previous, like a high-risk definition. So I want to say that we're going to have a different staging probably in the next couple of years.
So I have a question. Early on, you can have MGUS, and then you can smolder for years, and then it can develop into myeloma. So the decisions are made through that whole process, and they're pretty clear decisions that are given to you from the healthcare provider. They kind of tell you what you should do. And so the first stage is always the 2 shots. I don't know the 2 named the drugs, but the 2 shots in the stomach, along with some Revlimid.
Mm-hmm.
And then that you hope that puts you into remission.
Yeah.
Where I'm having trouble is there's no one that will ever tell you that you should do the transplant or not. And you can even say, like, hey, what should I do? Should I do the transplant, or what do you think I should do? And they go like, well, that's up to you. But so only then do they not give you the decision. So no matter how hard you pry, they'll never say, yes, do it, or don't do it. And I just don't understand why there's not like a clear, like, you should have it done because of this. You need to have it done, and you're a perfect candidate for it. Or you shouldn't do it, and here's why. I just don't understand. Maybe you could help me explain that to me.
Yeah, so that's, okay, so I have a struggle with that. Okay, I am a transplant doctor, okay? So like my main job, like I actually train in a transplant, and that's part of chunk of my thing, but I decided to only do it in myeloma, and then that's why I just become a myeloma expert. When it comes to the transplant, and I guess it's also the generational thing, and I can tell you, because when I'm looking at the doctors that are older than me or from previous generation, they have a better language compared to ours. That basically they say like, we're gonna do this. That's right. But then you come to me and I want to say, okay, so this is an option. I'm toward this one. I feel like this is important and this is this. But this has this side effect, so I want you to decide about it. I guess the reason for the transplant is just a little bit complicated. It's 3 months of your life. It's not easy to go through it. And chance of the easier part is the chance of dying is as much as dying from the medication that you're receiving with the DARA VRD. So it's not that we are killing you, but we mess up with all of your environment. It's like a nuclear blast in your body. You lose your hair, you're gonna have GI issues, and because of change of a microenvironment, there is a 1 to 2% chance that you develop acute leukemia or myelodysplastic syndrome, that basically different type of cancers as well. Because of the side effect and how huge it is, and it's commitment, that's right, it's expensive, you have to take a day off and everything for 3 months. So because of that, I guess when the people talk with you, they just say like, you decide your poison basically, because that's a poison, that's right? You're gonna achieve something from it, but that's a choice that you have, because you can just say like, I don't want it, and I risk, and I trade not going to the deep remission, but staying with the medication, then I'm not gonna just lose a lot of things through the side effects from it. So, like I said, they are filming it, so I'm not gonna say it, but like everything in like myeloma is a trading, so that's why you have that option. You wanna just see what exactly you're trading. But still, I feel like everyone with newly diagnosed myeloma, unless that they are 80 years old, they should be seen by the transplant doctors, and they should get evaluated. And it's easier for us to tell you if you get benefit from it or not. I don't think that should be the general oncologist telling you that you're not eligible based on your age, because we do look at a lot of things. If I'm, for example, concerned about someone may get the leukemia from it because of their age or they're older than the usual, we do actually send a special test and they look at all these possibilities, and we can just kind of give you the risk of getting all of these things better than someone that hasn't done the transplant for any patient. So I think that everyone should get evaluated and then decide at the end with the data. And we do recommend it for everyone right now, almost everyone.
So then we've had our discussion. Would you say then the sooner the better?
So the transplant, the collection should happen after 4 to 6 months of treatment. because the quality of, like a stem cell collection is going to get affected longer you are on Revlimid. So you cannot come to me 1.5 years after you start a treatment and assuming that I can collect the stem cell for you. Probably is not. We are not going to even probably try because it's just not easy to collect the stem cells. However, some people, they choose to have a collection and just store it and use it later on because it can be stored and it can be used like decades after. So that's not a problem, but the collection gonna have a time limitation. But yes, we can collect, move forward with the transplant a week after, or we can collect and then delay the transplant for a couple of months or years, or just wait until the relapse happens and you need the transplant and do it then. There is a limitation with the transplant regarding the age, because again, like we've done it for 78 years old, 79, I would say like probably not. That's a good age to do, but usually we just stop doing the transplant like 78, depends on what's your functionality is. And then, so for example, if you're 74 and you don't want to do the transplant, don't even bother to collect because it's not going to happen in the next couple of years. Hopefully you are not going to be in remission with your treatment for another 4 or 5 years, so you're not going to be in a window receiving it.
Okay, any more questions? Yep.
Regarding neuropathy, it was my understanding that Velcade was the primary contributor, but recently I've read that Revlimid can also play a role in neuropathy. Can you comment on that?
Yeah, so Velcade is more, so 30%. But like a Revlimid is around 5 to 10, it's just very low. But still it can, yeah. But when it comes to the neuropathy, again, it could be medication induced, but also could be a lot of things. So when you go to the myeloma population, again, like the age is a little bit, like the young age is less common. Like for example, less than 30 years old is only 0.8% of population would have the myeloma. So just imagine 65-year-old already have a diabetes, for example, like could have the neuropathy, maybe hasn't developed it, and then get the Revlimid. Is that Revlimid or is that a diabetes? Just because with the dexamethasone, we kind of increase the sugar as well, that could damage as well. So when it comes to the neuropathy, outside of the Velcade, it's just really so hard to just say which one is which one. So that's why we don't blame the Revlimid as a first agent, but it's possible in 5% of population as well.
Okay, anyone?
And it's not only Revlimid, a lot of other medication also.
Yes, Dr. Efron.
Yeah.
The question I have is, once you've been diagnosed with multiple myeloma, how is it determined what treatments that you will receive? How do y'all go about it? Is it when you're in the high risk or low risk as the determination what type of treatment you will receive?
Yeah, so high risk and standard risk is very important. Having the amyloid, non-amyloid is important. And then also what kind of medical history you have is important. But if I want to just choose one thing over all of these, it's going to be the frailty. Because if you're already very frail, so I know that with this medication, I'm going to put you in a hospital, you are not going to get out of it. So then I wouldn't choose the most aggressive one. So we start with something, it's just we are looking at the risk of like how much you can just give the medication without putting the patient in risk, but just also have get the effectivity of the medication. So that's why if you look at all of our data getting presented, we said transplant eligible, non-eligible. It's basically transplant non-eligible people are the one that either very old or they're very frail. So that's the part that we're talking about. So frailty is very important. And again, other medical history. So for example, if you already have a neuropathy, I prefer not doing the Velcade for you compared to the other medication that I have available from the beginning.
Okay, any questions? Okay, if not, we get a lot of questions about clinical trials. So what is the difference you've been seeing with the clinical trial data versus real world data? And also you were talking about the trust. How can we kind of build that trust to get more diversity into those clinical trials?
Okay, so first of all, for myeloma, we always recommend clinical trial before the standard of care. So all of these medications are available because of the clinical trial, and all of them were clinical trial like a couple of years ago. And there's so many good medication actually in trials right now, just getting evaluated. The example of that Dr. Anderson just has the patient right now, 6 years in, it was a clinical trial, basically. Your question is how.
Well, you were talking about how sometimes we don't get diversity enough into clinical trials, but like what we were saying, there's a lot of Black patients who get diagnosed, but we don't get them into the trial. So how can we kind of build that trust to get more people into doing the trials?
Oh, the trust is so hard to just build it without just giving it the time. That's right. You have to just let the time goes and just not based on your word, based on your action, you prove the point that actually I'm not doing the same thing that happens in 1960s, right? So I would say the time going to help, because, and also all the policy that FDA put it in place, so to just make sure that we are not going in the wrong way anymore. But goes to, I don't think that African American and not in a trial is only the trust, because I have so many African American patients and I put them in a trial easily, or at least we have a trust. But the problem is the trial is just so restricted when it comes to the myeloma patients. So for example, until recently, so they always say that if your neutrophil count, again, just show how your white BCs are, is less than 1,000, you cannot participate in this trial. So we know that the people from African descent, they have a normal variation that they can have a low neutrophil regardless. This is a healthy situation that they have. But they are the ones that be excluded from all of these trials just from being normal, but being from that descent. So that's something that now FDA kind of recognizes and is just trying to just kind of avoid. So this way, we don't remove them from the eligibility just based on what their biology is, or the differences between the white people, basically. And the other thing is, for example, we know that African American, they have more kidney problem regardless of myeloma, just because of the high blood pressure and everything like that. So these are the people that get removed from the clinical trial and they never become eligible because their kidney function is a little bit less. But we have a lot of a real-world data with the immunotherapy consortium that show that we can get the patient safely with an even lower kidney function through these treatments. So I guess what I do and what other researcher academic do, so we are proving the point in a real-world data. What you did and what restriction you put in place just doesn't need to be there, and you can just kind of increase it and open the door to more population to come. But it takes a time, to prove the point and then show it to the FDA, and FDA just kind of force people to do it. So that's why I feel like the diversity gonna be there in the next 20, 30 years, but we have to be patient for it. Yes.
And I think part of that is just education, because I'm 50, so the 1960 story don't apply to me. You know what I'm saying? So someone that might be 80 or 90, maybe even my mother who's 77, may think that way about the distrust. But the younger African Americans don't think that way. We do have more trust within the medical community. I'm in the medical field myself, and my mother too, so I think it's more education and then going into those communities to bring about more awareness.
Yeah, absolutely. So the education is very important. Then the reason that I said 1960, because someone told me that about it. And I'm like, oh yes, I saw it in medical school, but I didn't even think about it. That's my real example of one person told me exactly what it was, and helped me to just go back and think about how I'm going to just address that one, because it wasn't in my radar at all, and I kind of didn't even know it's important until they told me about it. But yeah, I agree. So that's what I'm saying. I have so many patients that they don't have any issue to go to any clinical trials. At least I never had any issue, and it never really come to my mind, but this restrict in eligibility criteria is like something that is very bothersome. And in UT Southwestern, I know like one of these lung cancer doctors actually did a lot to just get the NIH and FDA to change this neutrophil count for everyone. That kind of opened the door for many of our patients without issues.
Okay, well, thank you so much. There will be a Q&A session later today as well, so if you think of anything else, you will have an opportunity to ask questions then. But thank you so much.
Of course. Thank you for the opportunity, guys.